mini introduction because I didn't do the introduction when it was being recorded. Okay, so this is Dave Feinwachs. He's an attorney that was a general counsel for the Minnesota Health Hospital Association from 1981 to 2010, who is retired and is helping us out both from the Take Medicine Back perspective informally and Physicians for Patient Protection. So welcome, and thanks for joining, Dave.
Thank you. Well, I should start out by saying that I'm somewhat of a cynic when it comes to these issues, so I will disclose that as I go, and I must disclose proudly and loudly that my retirement was that I was fired in 2010 when I discovered something called rate cell cross-subsidization fraud, and the person who was running the hospital association at that time didn't want it disclosed to the federal government, and I told him I didn't agree with that perspective, and we parted company. For the last 10 years, I've been working on a number of issues involving the Federal False Claims Act and the physician autonomy. I'm a member of our local group here, which is called the Minnesota Patient Physician Alliance, and I serve on its board. In my role as a lobbyist and a lawyer, more as a lobbyist than lawyer, I've had some dealings with a number of the issues that you folks are dealing with.
There's a stalled vehicle ahead.
And I've also had some dealings with the FTC. And I will begin by telling you a brief story. Some years ago, we had proposed legislation in Minnesota that health plans be required to disclose publicly how much they reimburse physicians and other medical providers who are being blamed for the skyrocketing cost of healthcare. And the insurers went to the Federal Trade Commission and got the nascent policy wonks who work there to write an opinion for them that said, if people knew how much doctors and others were paid, it would drive up the cost of healthcare. Because if people knew how much something actually cost, it would result in higher prices, which had to be the most single ridiculous thing I have ever read, produced by the FTC, until 3 years later when the nurses got to them and said, we are essential to competition in healthcare. And the trick is, in dealing with the FTC serves two basic functions. They deal with deceptive and fraudulent trade practices and advertising. And then their other big job is to promote competition. And the nurses have done an outstanding job of convincing the FTC that advanced practice nursing is essential to competition in healthcare and to the continuation of a functioning healthcare system. So much, in fact, that the FTC has cautioned state legislators and legislatures, as well as regulatory boards, that they should think carefully about enacting legislation that impacts things like scope of practice and autonomy and supervision. So they were early to the game and have severely stacked the deck. I'm just telling you this as sort of a historical perspective. What we've worked on, and by the way, a lot of what everyone is concerned with differs from state to state. In some states, advanced practice nurses have to have supervision. In other states, they have an autonomous scope of practice. There may be hybrid models. Certain states, for example, Minnesota has something that can be cloned, which we did as a first in the country, called adverse event reporting. A lot of the discussion and the chatter here focuses on these people say, and it's not only nurses, but people bandy about the title doctor. And the real question becomes, what kind of doctor? Because the argument over the use of the title doctor goes back 200 years in England, when people with PhDs objected to physicians using the term doctor, saying it should be used by academicians, and they should call themselves physicians. And over the years, the use of the title has proliferated so much, in fact, that you can now get a doctorate in almost anything and call yourself doctor. So when people go after other, and I'm being kind here, healthcare practitioners, and say, that they shouldn't be able to use the title or protection of title. Protection of title is important, but its focus, in my opinion, should be on what kind of doctor. You can call yourself a doctor if you're a PhD, as I can, but never do. You can call yourself a doctor if you're a veterinarian, which they do. But everybody knows that they're dealing with a doctor of veterinary medicine when they walk into a vet clinic, because there's no confusion as about, where you are and what's happening. When you go to see a dentist, there is no possibility for confusion. When you go to a health system or a clinic, which has been purchased by a vertically integrated, monopsony type of organization, and people come in and introduce themselves as doctor, there is enormous confusion because patients think that they are doctors of medicine, which they are not. So I think the first thing that we need to work on is clarification of credential and what kind of doctor. So if someone introduces themselves, I'm Dr. So-and-so, fine. You have to tell me of what? Chiropractic, audiology. They're audiologists now refer to themselves as doctors. Take your pick. It's difficult for people, including the FTC, to argue against providing consumers information. And so one of the first approaches should be to mandate or attempt to mandate the disclosure of information useful to consumers, like I'm a medical doctor or I'm not a medical doctor. And you can propose legislation for that, and it will likely be easier to achieve that than to limit already existing scope of practice. So this is sort of a discussion about what's possible. The other problem that we have collectively is, I think almost everyone participating in this evening's discussion agrees that most people, and I'm going to use a pejorative term here, practicing as, fake doctors, not medical doctors, are probably operating beyond their scope, or a scope that's safe, but there isn't a great deal of hard data to back that up. And people tend to take advantage of that. If you look at things like the National Practitioner Database, which physicians are familiar with, nurses can be reported to the National Practitioner Database too. But since the types of organizations and people who can query that database are extremely limited, it does no good, because the people who have access to it want to expand the use and scope of advanced practice nurses. People like hospitals and health systems and insurance companies, peer review organizations, certain kinds of governmental entities, law enforcement. So we need to start thinking about a mechanism that can be created and employed to begin to collect data to show that there is in fact a difference. Because if there is a difference, then you can make real inroads with the FTC, sort of like medical doctor, ask for them by name. There's a difference. That's one possible strategy. One strategy that I have suggested in the past is most states, and this only will apply if your nurse practitioner, advanced practice nurses don't have a completely autonomous status. But states, for the most part, have things called conscience clause statutes, which are an outgrowth of the abortion issue. And while that's a third rail issue, the fact is most states have a law in the books that say that people cannot be forced to participate, supervise, endorse, or otherwise take part in medical procedures that they find ethically abhorrent, personally disagreeable, whatever the case may be. This is not a panacea, but it is possible to expand these conscience clause statutes for those states that have them, and also have supervision requirements to say that doctors cannot be retaliated against for refusing to supervise, advanced practice nurses where the state requires supervision. That's a possible approach. There are a variety of other possible approaches. We have in Minnesota, and I think we were the first, I'm sure you're all familiar with the so-called never events. We collect data, and other states may now do also, about never events which occur in healthcare facility. And there's a list put out by the National Council of Quality Assurance, whatever they call themselves these days. And these never events are reported anonymously, but a statute that requires their reporting is fairly easy to enact. And a statute which requires their reporting while still maintaining the privacy of individuals, but identifying what type of individual practitioner was involved in the never event, could also be passed, so that some data could be collected to see how many times things go wrong, which aren't, and basically who's at fault. And these are the kinds of strategies that are going to be necessary in order to gather the data that you're going to need to accomplish your goals. You can go after, as I say, the title protection statute by saying that you cannot call yourself, no one is going to oppose a statute that says you cannot say you're a medical doctor if you are not a medical doctor. The problem is we have people who are legally allowed to say they are doctors without saying what kind. So a beginning step there would be, again, the credential must be disclosed without the patient having to ask for it. Name tag, you've got to explain it, because I'm sure you've all seen what I've seen. Prescriptions. I have people who are patients in various settings who have no idea that they have not been seen by a real, MD physician in years, that their care is being handled by a nurse practitioner. The use and continuation of nurse anesthetists was sort of the groundbreaking event in this area, and they threatened antitrust lawsuits, which frightened a number of organizations, including here in my state, Minnesota, into settling with them. And I will tell you right now that the use of nurse anesthetists is going to skyrocket because of the recently enacted No Surprises medical billing law at the federal level, which took effect this year, which says that if a patient who has insurance goes to a hospital which is in their network, the hospital may not bill for things like an anesthesiologist who may not be in the network. The hospital eats the cost. That is going to give hospitals and health systems an enormous incentive to do it as cheap as possible. And as cheap as possible means hiring nurse anesthetists. So there's going to be growth in that area. And again, unless we have hard and fast data on what's going on and what problems develop, other than just sort of anecdotes that we hear from each other, we're going to have some difficulty in explaining why that shouldn't happen, because they're going to wrap it up in terms of cost containment. From the FTC's perspective, the FTC will always will never argue with you that people shouldn't know what's going on and have a right to know. They will give you an argument about competition, because a lot of the people writing these reports and a lot of the people you're working with are used to the now common experience of telemedicine. They're used to visiting minute clinics and other settings where they may never see a physician or realize the difference. And to them, it's beginning to appear there is no difference because they have no experience. So these are some of the hurdles that need to be overcome. Another strategy that I think is useful, and I myself have used, is there is a federal law called the Federal False Claims Act. And unfortunately, over time, the federal government is getting somewhat less interested in who is ripping them off, because the federal government thinks they're paying for certain kinds of services, certain level of care, certain kinds of practitioners in their Medicaid and Medicare program. And frequently they're not, they're being defrauded. You have technicians performing invasive procedures, which then an MD might sign off on and is billed to the government as if the MD had performed the procedure. In many circumstances, that does in fact constitute fraud and is actionable, and it can be reported to the United States Attorney. There are lawyers who specialize in this kind of stuff. They know how to do it. It can be an effective means of, if not striking fear into, the people you want to get the point across to, at least making them aware of the fact that you're upset and you're going to do something about it. I know that there has been talk about unionization because these days more and more physicians are employed, and being an employee is the entry prerequisite for being able to unionize. Many people consider this kind of a dirty term and demeaning from a professional standpoint, and it may well be, but as the problem gets worse, I assure you, people will look towards this as a way of dealing with the large organizations or the corporate practice of medicine that you're concerned with, because the practice of medicine has in this country become corporatized. There is no debate about that. So the problem becomes, and in the attack on these kinds of corporate things, more and more the courts, and again, this varies by state to state, but the majority of courts sort of take the view that, well, times have changed and things have moved on. In the old days, you couldn't be a member of a clinic group unless you were a physician. Well, then the hospital bought the clinic group and started calling the shots. And of course, they weren't physicians. So the courts made exceptions and modifications. We can't undo a lot of what has been done. I think we have to focus on creating new and innovative strategies to deal with the problems we now see. And again, it's going to differ state to state. So rather than, my spending the entire meeting, telling you about this, I would say that, you're going to need to have a real organized corporate presence. You're going to need lobbying assistance, because if you're going to change state laws, it doesn't happen magically and it doesn't happen easily. Bad things happen quickly, good things take a while. And in selecting lobbyists, there's basically three kinds of lobbyists. There are lobbyists who can raise money quickly for legislators and candidates running for office. There are lobbyists who have personal relationships with key lawmakers and people in power. And then there's the third kind. There are lobbyists who have information, and they are probably the least important of the three. And I was in that category. My principal utility is, and I should preface this by saying that the legislative process is like a courtroom process, except that not only does the evidence have nothing to do with the verdict, but jury tampering is not only permitted, but it's encouraged. So when people came in with nonsense reports or misstatement of facts, I would frequently go, that's not true, and I can prove it. Here, look at this. All three of those kinds of functions are necessary in order to get laws changed. And so in a sense here, what you're on the verge of is a new medical association, a virtual medical association in a world of, TikTok and the metaverse and all of this other kind of stuff. The day of the old-fashioned medical association is over. Most medical associations, not all of them, but the overwhelming majority of them have become useless. The AMA makes all its money selling coding books, and state medical associations have their dues paid by the organizations that employ the doctors they're supposed to represent. So they have no agenda items that would cause trouble for insurers, health systems, or any kind of integrated corporate structure. So you're not going to get any help from them. So that means you got to build something from the ground up. And in a sense, it's kind of up to you. So having said that, yeah, I'd be happy to answer any questions, to talk about things that we've done here and approaches that can be taken in trying to accomplish change. But you need to be aware of the fact that in 2014, Federal Trade Commission basically issued a report that said advanced practice nursing is the way of the future. And if you want to have competition in healthcare, you got to have these folks. And, you know, that was a bad move, but that was also 8 years ago. And it's been kind of bobsledding downhill ever since. So not only do we need to turn it around, but first we need to slow it down and stop it. So, and I am not familiar with what actions you've taken with the FTC. I would love to hear about those. But I know that in talking to some of the lawyers that work with you, we've exchanged some information. Recently, there's been some case law suggesting that the racketeer influence corrupt organization laws might have some application here. And I have always suggested that you know, the problem with healthcare will be the development of monopsonies. Most people have predicted that within the next decade, all of healthcare will be controlled by a max of 4 corporate entities nationwide. And if that occurs, you know, you're just a tiny cog in a very large machine. And the day of the individual practitioner, you know, for many kinds of medical practices has already sunsetted. And they have retired out or thrown in the towel and said, I won't do this because I won't compromise patient safety or quality of medical care. So we're going to need kind of a coordinated strategy to deal with this, but there's a number of ways you can use existing laws, and I am very fond of using laws that are already on the books, because the fact that they already exist makes it more difficult to argue against their expansion. You know, people, if you propose something that's absolutely novel and brand new, people can say, well, that's crazy. Nobody's ever done that. If you propose tweaking something that's been on the books for 40 years, it's a much more difficult argument. You know, why shouldn't this apply to this situation? It's been the law of the land for 4 decades. You know, and that, for example, would be providing anti-retaliation protection for employed physicians who refuse to participate or supervise mid-levels or sub-level practitioners. And now, with courts ruling that the doctor-patient relationship is established, in some cases, even without a physician, a doctor, ever seeing a patient physically, there's even more reason to have those kind of anti-retaliation provisions. In Minnesota, we've already got case law that says if a hospitalist gets a phone call about what to do with somebody and they discuss it with the nurse and things go south, it's the hospitalist who's on the hook for the malpractice. Well, if it's your insurance and you're on the hook, then you should have the right to decline the supervision, or at least have it be a discussable issue. Now, I recognize that, you know, many people are thinking, oh, I'll get fired. And depending on what you do and where you are, that's always a possibility. But nobody said it would be easy. The other thing you have to recognize is that there's a bunch of docs out there who, for enough money, will do, you know, whatever it takes to get them enough money. Minute Clinic started in Minnesota. It was invented by a doctor who then sold it for all the money in the world. And now Minute Clinic is considering hiring doctors as well as nurses to staff the Minute Clinic, you know, which is basically a clinic with a McDonald's reader board pricing system. And if they add a little diagnostic radiology and some lab testing to that, you know, they got a whole new thing. The other thing that I am a fan of is the repeal of certificate of need. I believe certificate of need has been a dismal failure. It's totally anti-competitive. It stops doctors and venture capitalists from setting up hospitals and other entities to compete with overpriced, poorly staffed alternatives. And I think that people at least ought to have a shot at doing this, because I have never believed that physicians or technology are the cost drivers in healthcare. I believe, and I have written somewhat about the fact that it is things like pharmacy benefit managers and what I describe as a system of legalized kickbacks that has driven up the cost of healthcare, and not what individual physicians might charge for their services, or even the operation of a hospital that actually ran like a hospital as opposed to a business entity. So those are the kinds of things I believe need to be considered and that we need to look at. But I believe that you will find it to be a mistake if you tackle this head on, going, they shouldn't be allowed to compete with us. I think you need to start from the platform of the patient needs to have enough information to make an intelligent and informed decision and choice. That's a very hard argument to be on the other side of. And most patients don't. I've lost track of the number of patients that I've had to explain to that all the doctors at such and such a place do not have the same first initials NP. That's actually a credential, not a name. And patients don't know that. And the FTC doesn't know it. And when you get a prescription and the prescriber, is a, I think they call them PACs, physician assistant certified, that's not a medical doctor either. Despite, how vitriolically they will argue that point with you, they're not. And the patient has a right to know what the difference is, whether their insurance gives them access to medical doctors, which I believe all insurance does, except it is possible, I suppose, to write an ERISA plan where a large employer who can create their own healthcare coverage could limit it to some kind of weird system where that doesn't happen, but it would seem unlikely. So I think we need to begin from the standpoint of education and then ratchet it up, going, now that you know what the difference is, demand the difference in your favor. Because most people, given the choice, I believe if a patient is told, well, you have the right to see a doctor or a nurse practitioner, which would you choose? I know what I'd choose. I want to see a medical doctor. There are, unfortunately, people who are typically disadvantaged, who are so thrilled to have access to any kind of health care that they don't care. They're just thrilled that they can get access. And we have to be mindful and sensitive to them as well. And in the meantime, we're also dealing with the issue of Medicare Advantage and other kinds of things which will severely limit individual and patient choice. So this is the backdrop we're working against. But for the major issue, what kind of doctor are you? I think that's a winnable issue, and a campaign can be conducted, if not nationally, certainly on a state-by-state level for the protection of the title. So if anybody wants.
Yeah, thank you, David. Do you go by Dave or David?
Either one. Dave, I prefer.
Okay, wonderful. Dave, thank you so much. We do have a good number of comments, and I just heard you mentioned ERISA, which is a totally different line, but we should really talk about that at some point. And just for real brief context for everybody, ERISA is, I forget the heck it stands for. It's the law that governs plans or health plans for employer-based health plans, right? It goes along with Department of Labor, if I understand correctly.
That's correct. It's the Employee
Retirement
Income Security Retirement Act of 1973 or 1974, known in legal circles as every ridiculous idea since Adam.
Yes, and so that's something we can table, I think, for another discussion. But I love that because we have advocates within the health plan space that are helping employers replace their Buca, Blue Cross, United, Cigna, Aetna, Humana, all of the main bad insurers as we sort of know them, with transparent health plans for their employees. And so there's some latitude in there.
Yeah, and Dr. Lee, I'm glad you bring that up, because one of the arguments that's been going on for many years in ERISA, and it seems like such a simple thing, but they hate it. Employers, especially big companies who have ERISA plans, are immune by virtue of federal law from the regulation of their plan by state insurance commissioners and state regulators. So one of the things we had tried to do in the past is, the most common way an ERISA plan works is you take a big company and they hire somebody like a Blue Cross to administer the plan. What Blue Cross does is they give the employees of the corporation a card that has the Blue Cross logo and is deceptive in every way, because it makes it look like you have Blue Cross coverage. Then when something happens, and the most typical thing that used to happen, at least in Minnesota, is a woman would be diagnosed with breast cancer and she would have need for a wig. In Minnesota, our state regulators require that health insurance pay for that wig. ERISA plans don't have to do that. And people would look and say, look, I have Blue Cross. You have to pay for it. No, you don't. You have an ERISA plan. We suggested that those cards had to contain a simple statement that this is not an ERISA plan. I'm sorry, this is not insurance. This is an ERISA plan administered by Blue Cross. And Blue Cross became completely unglued at that suggestion, because, you know, that would have been terrible for them. And a few years back, there was a case in Michigan where Blue Cross was the administrator of an ERISA plan, and they were stealing from it by marking up internally the charges that were submitted by hospitals and perhaps physicians as well, and then keeping the markup for themselves and blaming the increasing costs on the medical practitioners, as opposed to the fact that they were internally inflating the charges. When they were caught doing this, they relied on a contractual term that they had put in their ERISA contract saying, you can't sue us because we reserve the right to do anything we want, and you can't do anything about it. They lost that case. They paid off everybody involved in that case, and they have done everything possible to avoid any discussion of that case, which, by the way, is called Hylex versus Blue Cross and Blue Shield of Michigan, which is a wonderful decision, because if you want to see how things really work, it's worth reading. But ERISA is another problem, because it's regulated at the federal level, not at the state level, and they can pretty much do as they like.
Dave, I have a question for you, because some of our strategies on the, with the FTC is really to get enforcement of the corporate practice of medicine. You had mentioned the doctors that are willing to accept any amount of money to make more money, and they become paper owners. And one of the big issues in emergency medicine is there's these large CMGs like Team Health and Envision that have contracts with the emergency department, makes it anti-competitive. They push out Democratic groups. They have, closed door deals with the hospitals, et cetera. And they have docs who may never step foot in that hospital, may not even be in the state, who are the paper owners of the corporation that's managing that contract. And then they get private equity investments, and they really control the organization. So, it's a pretty big bullet point for what we're trying to accomplish, is to get states to identify where there is illegal corporate practice of medicine occurring, and then enforcing the corporate practice of medicine laws that are in existence in many states. Historically, we've heard that there's always back and forth between the AG saying it's not their responsibility, it's the state medical board, and the state medical board saying it's not their responsibility, and then it becomes futile and no activity is taken, or no action is taken. Have you had any historical or any experience on CPOM laws, their enforcement, or any of the like?
Yeah, when I taught the issue at the University of Minnesota, and in the state of Minnesota, what you just described has been going on forever. The corporate practice of medicine is a fascinating concept, because I would argue that we have had, and for the most part tolerated, the corporate practice of medicine for at least the last 30 to 40 years. Now, in some states, they may be more stringent, but the minute we let hospitals and health systems start buying up physician practices and calling the shots, that is the corporate practice of medicine. The original corporate practice of medicine doctrine was the notion that if you had a group of physicians, you couldn't let somebody else in as a shareholder or a partner or a player unless they had MD after their name. It was both a protectionistic mechanism and a way to ensure that people couldn't hold themselves out as medical doctors who were not. And it has been in decline and decaying over the years. And again, with the FTC, the pitch I would make is it's important for the consumer to know who they're dealing with and who is calling the shots in their practice. I mean, in the patient's individual practice, who is recommending this, or who is saying, I don't need this procedure, because as a gatekeeper, they are incentivized by keeping a percentage of what they cannot dole out, regardless of the impact it might have on the patient. There have been many cases historically that have argued that HMOs and other kinds of insurers have been engaged in the corporate practice of medicine, but the courts have historically taken the position that a medical doctor is in a dual fiduciary position. You wear two hats simultaneously. You have a duty to your employer or the health plan or the ERISA employer, and you also have a fiduciary duty to the patient. And in my mind, of course, the second one comes first, which results in the uncomfortable circumstance where a physician has to tell a patient, this isn't covered or nobody's going to pay for it, but in my professional judgment, you need it. And then the patient either has to start an appeal or go through a process, but that's part of the problem. A physician's judgment is no longer the be-all, end-all when it comes to medical treatment. Depending on the type of insurance coverage you have, my personal plan, if I get somebody with MD after their name to say I need an MRI, the next thing I know, I'm sliding into the tube and hopefully not, being given recronium bromide instead of midazolam, but I get the MRI. In other places, there has to be a meeting of the so-called care team to decide if the thing that in reality costs $300 is going to be done. And that's part of the problem. On the one hand, some people are enamored by the concept of the care team. We're all players on this team. The flip side of that coin is people like me want to know who's the captain of the team, because I want to talk to the person in charge. So that is a potential attack that the FTC may resonate toward. But if you look at the FTC's approach so far, and if you look at the American Association of Nurse Practitioners, they make no secret. You can go to the internet and see, they have said the Federal Trade Commission, as part of its ongoing work preventing anti-competitive business practices and promoting consumer choice, evaluates state licensure regulation for advanced practice registered nurses. And in 2014, they cautioned lawmakers that maybe you shouldn't require any supervision. So we need to latch on to the key words there, which are consumer choice and evaluation, because consumers can't make an informed choice if they don't know what's going on.
I appreciate that. It's I think the corporate practice is what kind of drives all of these factors, at least, from dollars and cents being the focus and using lower cost labor, such as MPs and PAs to fill your shifts, et cetera. And I think it's at the core of it. It sounds like it's been battled before, but hasn't been won. Is that kind of what you're alluding
Well,
to?
I won't say it's never been won, and I know even lawyers practicing here who think it isn't dead in Minnesota, but I see no evidence of life here. We are so consolidated and integrated here that it doesn't appear to me to be a viable argument. But I can easily find you lawyers who will say, "Oh no, the corporate practice of medicine can still be undertaken." What you have to then distinguish is whether they're saying that because they want to take the case and argue it, because that's their job, or whether there's a realistic probability of success. And what I'm advocating is you kind of rank order the various strategies you come up with, give them scores and start with the stuff that has the highest success score.
Got it. Thanks. I think a question came up on non-compete clauses in physician contracts. It's always something that we're forced to sign, and you're not really given an option. Everybody signs it, so you got to sign it, and it could be 2 miles, but really they're like 20 miles, 60 miles, unreasonable, would make you unemployable if there was a wrongful termination or you were pushed out. Can you comment on non-competes and what physicians can or cannot do with regard to non-competes, and are they enforceable in the states in which they're written?
I can and I will, and you've just reminded me that this is a sign of advancing age. I forgot to give the usual required disclaimer that our discussion this evening does not constitute legal advice, because I can scarcely give legal advice in Minnesota. Many people would argue not only because of licensure, but because of knowledge base. But in any event, I certainly am not authorized to practice law in other states. Now, having said that, non-compete clauses are generally enforceable if they meet 2 threshold standards. They have to be reasonable in scope and duration. Okay, so one of the things you look at is time. If they, if you sign a non-compete clause that says, I'm selling you my practice and I will never practice medicine forever, that clause probably will not be enforceable. If you sign a clause that says, I'm selling you my practice and I will not practice medicine within 15 miles of the location of my practice as the crow flies, or within the service area of the hospital or whoever bought the practice, then the question becomes a little more thornier, not because the clause isn't enforceable, but because people will argue, for example, my favorite is the Mayo Clinic, who argues their service area is the world. And that used to be true before 9/11, but it isn't anymore. So you look at, typically for a clause to be enforceable, it will be 2 years, and the service area will be a factor. So if it's a hospital, you will look at where the hospital's patients come from, which zip codes and so forth. And if you're working in a hospital in Wilmer, Minnesota, and the non-compete clause would stop you from getting a job in Minneapolis, probably not enforceable. But flip side of that coin, some years ago, while it wasn't medicine, there was a Jewish mortician. Yeah, we have a Jewish mortuary in the Twin Cities area, which was bought up and consolidated, and so he moved to Duluth and started a mortuary who practicing for Jewish folks, and he was sued to enforce the non-compete clause that he'd signed, and he said, "Well, this is ridiculous. I'm in Duluth." But the people who sued him were able to show that when Jewish folks died in Duluth, they used the services of the Jewish mortuary in the Minneapolis-St. Paul area. And so that clause was in fact ruled enforceable. So they are very fact dependent, but the 2 basic issues are scope and duration. They can't last forever, and they can't confine you so much that you can never practice your profession again. In fact,
Thank you.
one of the guys running for governor currently is a doctor, and I will mention his name only because you may have seen him on television. He's a conservative guy named Scott Jensen, and he had signed a non-compete clause which stopped him from opening up a competing clinic within 15 miles of the hospital he had left. And the issue became 15 miles, and the court ruled that it was 15 miles as the crow flies, because he took the position it was 15 miles as one would drive to get to him. And I believe he lost that one on the argument that he wasn't a crow. So, a lot of times that's what those things boil down to.
Thanks. Hey, Mitch,
Can
you
I
want
say
to?
something real quick?
Yeah, sure.
Hi, I'm Mercy. I spoke to you on over the weekend regarding non-compete clauses. I'm in Indiana, and this is not an issue for me personally. I'm an emergency physician. I'm not even working right now, but in Indiana, we're the land of the huge healthcare oligarchs, IU Health, which owns like 40 hospitals in the state and 300 clinics in the state. One issue that I've heard frequently come up among physicians that are employed by IU and Ascension, which is the second largest, is that especially now with a lot of satellite locations where they are often kind of forced to practice, like twice a month they have to go down south 2 hours away and run a ancillary clinic, and then 2 days a month go up north, or they have to do telehealth visits in different parts of the state, that these non-competes are now basically restricting them to be able to move anywhere, because they may have a 25-mile radius, but it's not just from their main practice location, it's from any of their ancillary locations. And so oftentimes these physicians, in order to break a contract, they have to leave the state. So I don't know if you have any additional comments on that type of thing that's happening, but I've heard that anecdotally.
No, it's true, and that goes back to the service area issue, because the organization will argue that any place they have a satellite clinic, their service area extends to, and so whatever the radius clause is for the non-compete, their argument will be that's where you draw the line. The other problem you have with non-competes, and this was pre-pandemic, I don't know now, but fast food restaurants were using non-compete clauses for managers. So, if you worked for a McDonald's or a Burger King, you had to sign a non-compete clause, and you couldn't be a fast food restaurant manager within 50 miles of, any place they had a location. And if you're McDonald's, that could be a real problem.
David, yeah, thank you for this background. And I just wanted to add one thing before I think we can open it up to folks just asking questions. I see Etch, who I think will have introduce who they are in a minute. And but I wanted to ask you, with regard to these non-competes, that McDonald's example is a good one. I mean, it's ridiculous, right? You're stopping somebody from working at Burger King. I mean, that's absurd. But in this case, we're really truly preventing physicians from serving their own communities, and it becomes more of a public health threat. You could argue that McDonald's and Burger King are both public health threats for existing, but in this case, a lack of physicians are, right? And the FTC theoretically has the ability to bar, the Federal Trade Commission has the ability to bar what they deem to be unconscionable contracts. And we're considering asking them about, as an ask to bar that language, recognizing that this is a public health threat and it's unconscionable to stop physicians from practicing in their own community. We just saw that 223 physicians left Asheville, North Carolina, where the Hospital Corporation of America, HCA, bought out a nonprofit in a very shady deal, and now has a virtual monopoly there. And they've driven physicians out of the community, both willingly because they wouldn't want to work there, and also because of non-competes. So I'm wondering what your thoughts are, if that's a path worth exploring.
It's a path worth analyzing. HCA is the subject matter of many cases in antitrust law, again involving service area. And the problem is you have to show that there is harm to the consumer before the FTC becomes interested. Because the phrase you will hear repeated over and over again in the area of antitrust, whether it be by the FTC or the Justice Department or whoever, we're not here to guarantee that anybody makes a living. We're just here to guarantee that competition is not harmed. And as long as there is competition, which includes competitive alternatives, and the public has some place to go, these organizations typically conclude that the public is not harmed. So for example, if there's a nurse anesthetist, but no anesthesiologist, no supervision is required, the FTC, would likely say, where's the beef? What's the problem? So, the difficulty there is because they're factually, driven cases and fact-intensive cases, you have to show that the consumer is harmed because there is almost no concern, and it's prejudicial and it's unfortunate, but the average FTC policy wonk is going, okay, so we've got a rich doctor, a group of doctors making complaints about a contract they entered into. We don't care. And the trick is to make them care.
Thanks, Dave. I think we probably could use even more guidance because that's at least our main direction right now, or call to action, is working with the Federal Trade Commission or trying to pull the levers to make this an issue that they care about. And our brilliant and somewhat long-winded journalist, not ours, but Maureen Tasic, wrote a long chat in there essentially saying that the FTC, I think, hasn't really tried to do much since 1970s. Lena Khan is felt to be an activist chair right now.
She wants to throw out the consumer welfare standard. That's what our whole mission is about. And I say me, I'm kind of part of this crew, the American Economic Liberties Project, that's literally trying to resurrect antitrust law and all kinds of laws from the 1930s and use it again. So there are people there. There's the chair who's controversial, and there's another Democrat who's decent, and then there's a Democrat who might be confirmed, I don't know, and then there's a lot of angry staffers who are used to doing nothing, but they are desperate to throw out this bullshit standard to remove bullshit economic studies from the study, and to restore anti-competition, to an interest in anti-competitive tactics to the agency. The Biden administration is on board. So, that's our hope. And that's the audience that there are obviously, I think that the way that these roll-ups circumvent the corporate practice of medicine using these sham companies, I think that possibly counts as a deceptive practice, but we're really trying to go for something, around competition. Labor monopsony is something that the Biden administration is especially interested in. And you see it now with there's a lot more Democrats talking about how, actually the cause of inflation is concentration of corporate concentration. I think that private equity is hyper intensifies that, price hikes and slashed wages and these kind of anti-competitive harms, because that's what they're looking for, and that's why private equity is invested in healthcare, because there's no competition. It's a natural monopoly. Ultimately, when something's a natural monopoly, you have to regulate it like a utility. That never happened in healthcare, but I think that ERs might be the place to start. because we have this unfunded mandate and EMTALA. Anyway, that's just my general thought, but I wanted to give a little defense of the FTC because the crowd in there, the crowd that we are trying to pitch, wants to make a huge, a massive departure. They believe ardently with every fiber of their being that everything the FTC has done in the past 30, 40 years has been, a failure, and that they need to, kind of recreate the 40s.
Yeah,
Sorry.
thank you, Mo. And I guess we're saying that everything the FTC has done or not done has been a failure, and we're reconstituting hopefully an effective FTC. And I'll just add to the folks from PPP who may know that the FTC sort of, or have the perception that the FTC sort of sided with non-physician practitioners, saying that, oh yeah, they can have independent practice because that's competitive with physicians. That was probably a different FTC, and B, an argument that was speaking the language of the FTC. So let me throw that to Dave, and then I do want to get to Etch, whoever that is, because they've had their hand up for several minutes.
Well, I certainly hope what was said about the FTC is true. I'm not optimistic, because frequently people are told what they want to hear, but I would certainly hope that they're interested in looking into that. As I said at the outset, they have two primary purposes, and one is, to prevent the deception of people, and two is to ensure competition. It's easier to talk about the prevention of deception and harder to talk about competition, especially as people attain autonomous scope practice status, because then they are in fact your competitors, and what you say against them begins to sound more and more anti-competitive. And the antitrust laws, and it's not just medicine. The antitrust laws have been around since the 1890s, 1898. These are not new laws, and for the most part, they have not kept up well with developments in technology, and that's not limited to medicine. I mean, you just look at things like Facebook and other kinds of things, Microsoft, Windows, all sorts of things that now invoke and raise antitrust questions that are not so easy to answer anymore, because it's no longer about gasoline and tobacco prices. It's about more complicated issues. So I hope you're right, and there's a new breed of character there. And if so, by all means, keep hammering away, but you're going to need data. And until you get that data, I believe that the thrust should be on the consumer. In order to be protected, needs to understand that there is a difference and be informed of the difference as a threshold issue. Because I can't, I know someone will argue against that. It'll confuse them. It takes time out of the day. It's wasteful, but I don't think those are compelling arguments.
Thanks, Dave. And I do want to get to Etch, whoever that is on the comment here. From Mo's discussion, I think we will have more conversations about the FTC. Right now, we have a big call to action, including one where if you know NPs and PAs that sort of see things clearly, that they are being abused by the corporations and staffed inappropriately, then we have a call to action that we'll post with the PPP folks and Take Medicine Back, where if you know any NPs and PAs that can comment on the FTC's website for their active solicitation of merger comments, please have them do that. They can do it anonymously. So if they're worried about retaliation from colleagues or their professional societies, they can just post anonymously and say why they're doing so. And that's part of our goal here. And I don't know if we're optimistic. Mo says she's not optimistic. I'm not terribly optimistic. I just think that we only have so many opportunities, and we have an alignment of opportunities with the FTC right now. And if things keep going south, not just in medicine, but emergency medicine, but in monopolistic behaviors in America, then we're probably just going to see a devolution back into another January 6th attack on the Capitol, and none of this will matter because we'll have a breakdown of society. So that's my pessimistic side of things.
Well, there are statistics for emergency medicine. I mean, the rate of production of EM practitioners, at least among MDs, is small. The rate of attrition is higher, and the number of nurse practitioners wanting to get into the field is increasing. And it wouldn't be difficult to do the math and show that within a decade, it may well all be advanced practice nursing. Their principal problem there is that the federal government does not support that at this time. They insist that there be physician involvement in emergency room practice. And there's been a number of cases, there's been many cases around the country. There's been a number here locally where people have died because of only nursing involvement in, what turned out to be complex issues. So, that is a good one to hit them with.
Thanks, Dave. Let's go to Etch, who's been patiently waiting. And first, if you can introduce yourself beyond your Etchy name.
All right, thanks a lot, Mitch. And first of all, thanks everybody for letting me join in. I was invited by a member of the PPP. My name is Ed Shaheen. I'm an emergency physician. I'm an old guy. I've been around. I've been practicing emergency medicine since 1991. It's kind of interesting listening to Dave talk. As he talked, I'm thinking it sounds like my journey through emergency medicine of realizing of all the problems and all the corruption and issues. I've been asked to leave or have been forced to leave places because I've brought up certain illegal practices, whether it's EMTALA, whether it's billing, fraud, et cetera. And it doesn't seem like anyone seems to care. Everyone shovels it under the table because the powers that be. One thing I wanted to mention in terms of the Sherman Act back in 1890, I mean, that was talking about free competition. It seems like that it seems to be used only when it's convenient, as in the case of the nurse practitioners, which is, apples and oranges. Yet they have no problem with the failure of competition. For example, in emergency medicine, how the majority of emergency physicians are captive employees of the big, private equity groups. One of the big concerns, and I pose this really to everyone, I think I guess Mitch needs to be complimented because I think he identified this and is what led to him starting to take EM back. But just want to pose this to is I wrote my approach was I thought I would go through the channels that exist. I'm a member of American College of Emergency Physicians. I guess I should tell you this. I'm a board certified emergency physician. I'm currently the president-elect of the Louisiana College of Emergency Physicians. Along with one of the members or a couple members of PPP, we started an organization called Louisiana Physician for Patients. We've also started something called the Louisiana Rural Physician Coalition. And basically, the idea is to try to bring medicine back to the patient physician to try to protect the patient. But let me get to my point. I wrote several resolutions, and Dave, when you were talking, I was just laughing to myself. I wrote several resolutions for the American College of Emergency Physicians to require or put a resolution to support making people identify themselves when they saw a patient, to say specifically exactly what you said. I am a medical doctor or I am not a medical doctor. Simple as that. You can't believe the pushback that people had. Another issue is about the non-competes. There are some states that have non-competes, but there have been some challenges to that if it's a danger or harm to the public. And a perfect example, I practice in a place where we didn't have a lot of neurosurgeons, and a neurosurgeon basically got fired by one hospital. He couldn't work at another hospital. Well, of course, I'm the guy that's on duty when a patient came in with a head bleed and they ultimately died because the nearest place was 120 miles away and they herniated before we could get them there. And so those type of things, I think if you push the legislators and you embarrass people, they have to act, they have to do something. But getting back to my point, the people that supposedly represent us, the American College of Emergency Physicians, the AMA, et cetera, the people that have the ear of the government do not actually represent us. I mean, they're not willing to pass the things like my resolutions that were pro emergency physician. They don't want to hear about it. They don't want to get behind that sort of thing. And that concerns me. So it's like you're in the twilight zone. The people that are supposed to be taking care of you are the people in bed with the people that are fighting you, the private equity, the hospitals, et cetera. So your thoughts, Dave, in terms of how do we actually go about getting something effectively done when those who, at least the government believes represents us, don't take forward the things that are important to us?
Well, the first thing I would say is, one, we are kindred spirits, and I would have you know that my wife is from Louisiana, and I have many pleasant memories of sitting on the Lake Pontchartrain Causeway in bumper-to-bumper traffic, sipping on a drink when it was still possible to drink in a car in Louisiana, but those days are gone. But you are absolutely right in what you say about these organizations. They have been co-opted and basically hijacked. And in terms of the credentialing thing, the problem with medical association and its resolution process, it is designed to be cumbersome and to fail. Most states have a patient bill of rights law that grant patients certain rights. You have a right to see your medical record. You have a right to this. What I would suggest is, and you don't even need an organization to do this, if you know your own legislator, to amend that existing law that says that the name tag must not only contain the credentials, but that the person treating you must tell you what they are. You would amend an existing law. Going through the process of the powers that be may not be the best way to do it. It may be best accomplished by getting a group of 10 or 20 people together and finding out who has relationships with legislators, because it is a simple enough amendment to put onto the existing law and then stand back and watch the fun of seeing who argues against it. No, it's a bad idea to tell people that I'm not a real medical doctor. Really, tell me why. The medical association isn't going to do it because they don't want to piss off the insurers and the people that basically they don't want to bite the hand that feeds them. So they are placating you. You may want to consider working around them, and it's not that hard to do.
What other comment just to make, and I appreciate that, and we are in Louisiana anyhow trying to work on that and trying to get our legislators, I guess, for lack of better words, educated and understanding what our concerns are. As for the non-competes and the contracts that are signed, and how you say a lot of times our trade organizations are in bed with the payers and the private equity and hospitals and so forth. I lost my train of thought here. I find, or what are your thoughts in terms of taking the lawsuit route? I mean, I hate to say it or break it down and make it sound so simple, but it seems like money is really what's driving the ship on most everything. I mean, you can explain that, why there is the nurse practitioner creep, why hospitals and private equity want it, why they're trying to change staffing models, et cetera. If you hit them in the pocketbook, and it seems like at least the courts are being a little more favorable to the physicians. There's the one lawsuit I think most everybody's heard of, the one with, I guess it's Brossman up in Kansas City, who got a judgment against MCare Envision for, making him leave the emergency department to go respond to codes, which is commonplace in almost every emergency department that you work in. If emergency physicians are willing to take the risk and file lawsuits and say no, I think that something will definitely happen. I think this is hopefully the dam is starting to crack, And I hope more people follow that that route. But I really do believe unless you hit them in the wallet, I'm concerned and pessimistic that things really won't change. It'll just be a cost of doing business.
And I certainly won't argue that point with you. You do need to hit them in the wallet, but be aware that the legal route is not quick and it's not cheap. And so, you know, I hope it goes as you say, but the problem with healthcare in general is the bigger the organization, I'm sure you've heard the expression, too big to fail, too big to jail. When you get to really large organizations, it's almost impossible to have a meaningful impact on them if for no other reason, every 401k in America has some of their stock in its portfolio, and people are reluctant to do anything which would cause disruption in the valuation of that stock. You know, consider, for example, United Healthcare and CVS and Walgreens and a bunch of other big players where they're simply too big to fail and too big to jail. The problem with the non-compete clause, and I don't mean to, you know, basically you're making an argument that physicians, who most people view as very, very intelligent people, have entered into a contract, and you know now they're getting screwed. And so it's hard to convince people that they should be concerned about that. It's not impossible, but remember, you know, physicians as a group are considered very highly educated, very affluent, and there isn't a lot of sympathy for that kind of thing yet. And, you know, that may change over time, but right now it isn't there. I've heard of a case of a large system, I can't mention it, where in hospital facilities, including the ICU at night, no one is present. They've installed baby cameras. They're basically not running a hospital anymore. They're running a Motel 6 with baby cameras, and there is a real doctor in the ER, but somehow they figure that that person is going to drop whatever they're doing, you know, and go up 3 floors to see who's just coded. And realistically, that's not possible. That could be the basis of a winnable lawsuit.
Thanks, Dave, and thank you, Etch. It was great to meet you here as well. I want to be mindful of the time. It's 9:23. We usually do an hour and a half total. I am going to stop the recording in just a moment, but I want to give Dave at least a last word here just to tie things up, and then we'll open this up, discuss a couple of other items here, and also just throw this out there that we do have a group of attorneys, and I'm really excited to have Dave sort of come on board just for idea sharing, and we're hoping that we can come up with the most effective strategies, because we are up against big money and corruption, and so we do have to be asymmetrical warfare. You know, a little bit of I don't know, Ukraine. I guess I don't want to undersell what's going on there, or say that this is analogous, but there are some similarities. So Dave, do you have any other final thoughts, and then we'll shut this off? You're welcome to stick around. We'll keep chatting.
No problem. You do have to think outside the box on these kinds of things, and it's always best not to, you know, keep doing the same thing over and over again, and, you know, hoping that it will succeed, or do what you've done in the past. A little creative, out of the box thinking is probably your best move, and the ability to work across state lines. I've met some of your volunteer attorneys. They're excellent. Getting that kind of input and willingness to help and sort of sharing ideas, I think can go a long way, because as I say, this is not a problem you're going to solve overnight, but if you make it a problem in the eyes of the consumer, you will win.
Thank you, Dave. And I think that's excellent. I just saw a comment from Mo, and I just wanted to mention this, that some of the other attorneys we're working with have picked up on this. Data on nurse practitioner in pointless testing and procedures would be very, very useful, or knowing the data on that. And I think that's starting to come up. People are realizing that. there is over ordering by NPs, and that benefits the corporations and hospitals that they are employed by. So apologies for butting in at the end there. Thank you so much, Dave. I'm just going to stop recording. You're welcome to stick around, and we'll bring up a couple other topics. Thanks a lot. And if Jay Hopkins is still here, maybe he can reframe. If not, I'll jump in.